and record today just so everybody can access it. I think it's the time of year where everybody's just getting normal colds and flus. And like, because of when we are, everyone's like, it might be COVID. And I appreciate people not coming if they feel sick. And thanks to those of you who reached out to me this morning to let me know. So just a couple quick things. So we had Dr. Blackman here on the Ethics and Professional Issues Day. It is showing up, that's good. And so we're now gonna cover ethical and professional issues on the 3rd of March. So where the psychodynamic section was. And so today we're going over diagnosis, and then we'll do the interview on Thursday. If you are well enough to come to class on Thursday, we're gonna do an activity. If there are enough people on Zoom, I can also put you in breakout rooms and you can do it that way. And then next Tuesday, when we talk about intellectual and neuropsychological assessment, we will have Dr. Jensen come over. She's in private practice, and essentially like a lot of her work is assessment. So she will be a great person to have for that. The other thing I wanted to make sure I pointed out is that you have your first reaction paper. Typically I make these due a week after the day it happened, but I didn't upload the video till this morning, so that didn't seem fair. So it's just a reaction to our guest lecture with Dr. Blackman. So, you know, a page or two. They're really not supposed to be onerous. They're just an opportunity for y'all to get points that aren't associated with the big paper. And so you just write a little 1 to 2 page paper. Again, in theory, due a week from today. I'll take it late if y'all need to be late with it. So we will start to have these maybe once a week, every other week, just depending on when we get to activities, essentially. I think that's it. Oh, the only other thing I wanted to say is if you want to follow along, I actually am using a PowerPoint. It's one of the few times I'll do it this semester. So if you want to follow along, it is posted here on the Blackboard page under diagnosis. So, alrighty, but I'm going to go ahead and start our slideshow. As I'm doing that, anyone either on Zoom or here in person have questions about anything I just covered? Alrighty. Well, let me.
Mr. Myers?
Yeah.
It's Elijah. I had to join by phone. I tried to join on my computer, but it said I needed like a meeting code, and I didn't know what that was.
Okay. Yeah, and that is listed on Blackboard if you ever need it, but joining on your phone is fine. I'm recording it, so you can watch the video later if you want.
Okay, thank you.
You're welcome. Okay, well, thanks for telling me who you are, because it only shows up as a phone number. Go ahead and check Elijah in here. Alrighty, and we will go ahead and get started. I'm just going to do one of these so I can talk to everybody at the same time. Alrighty, so we're going to talk about diagnosis, and we'll talk about the DSM. Related to this, Dr. Blackman did send me his article about the DSM, and so I've posted that on Blackboard under the DSM section as well, if anyone's interested. As I sort of exchanged with him on last Thursday, I also have problems with the DSM, but probably for very different reasons. So it'll be very interesting to see your perspectives that you get from both of us. So we have called abnormality or pathology or diagnoses a whole bunch of different things over the course of history. Things like insanity or disturb, things along those lines. I'm just going to try and see if the other way is a little better. 6 of one, half dozen of the other. And so, some of these are still terms that we use today that were like slang terms, right? And so some people still call this abnormality. Typically now we're trying to refer to it as psychopathology. It's not that you're abnormal, it's that you have a disease, a disorder that's diagnosable that we can try to help you with. But people had different ways of trying to describe this. Uses of Rosenhan and Seligman came up with like what makes something a pathology, and it's, you know, maladaptive for the person, it's harder for the person to process, it's unpredictable, they experience suffering, they're maybe irrational, they have observer discomfort, vividness, and violation of moral and ideal standards. Levine used the acronym IMAD, which hit on some of the same things essentially as this Comer one, so I'm going to go to that one. So this is deviance, and this is a big part of what we decide as psychopathology or abnormality, is how is this person deviant from cultural norms? And so what this means, and one of the reasons why I often have a hard time with the DSM, is that what is a pathology is often just defined by what's considered normal in that day and age. So clear example here is up until the 1970s, homosexuality was included as a sexual, a paraphilia, which are essentially the sexual deviances within the DSM. Obviously, we don't classify it as that anymore, but clearly shows these things could be problematic. Also, does it cause the person distress, right? That's a big piece of it. And so throughout the DSM, you'll actually see for the criteria for many of the disorders, right, that it essentially interferes with their personal, professional, or social life, essentially. And is it causing that dysfunction? Is it, you know, getting in the way of them being able to do things? And then one thing that is not a requirement but can happen is danger. And this is danger to yourself or other people. One real misconception that I'm guessing none of you have because you're psych majors or minors, is that there's this idea that people who are mentally ill are very dangerous to society, that they are the ones who are going to like kill you or implement the school shootings and things along those lines. And like maybe some of those people have pathology, but someone who has a diagnosis is much more likely to be a danger to themselves rather than other people. And so that's just something to keep in mind. And I have a picture of Danica Patrick here because certainly when she first started driving, people would have labeled her as abnormal because she's this woman who wants to be involved in a very male-heavy sport, right? Now, there have been people who have argued that mental illness itself, pathology itself, is a myth. So Thomas Zaz, back in the 60s, said it's not that people have pathologies, it's problems in living. He basically said it's kind of society's fault for not accepting them, essentially, which, you know, there's a grain of truth in that, right? You know, is it a defect or is it, you know, a belief that this person has a defect? And then he really was cautious about, like, should we be giving medical treatment, which back in that time still included some things that could be fairly barbaric, right? For people who are just different than societal norms. So why do we even have to bother with diagnosis, right? If we think that there are these problems with slapping labels on people, why? Why are we doing it? Well, one reason is laws. So there are laws that essentially say, like, you can get accommodations for mental illnesses, but if you have a diagnosis, just like you can get accommodations for ADHD, things along those lines, right? The biggest reason, to be perfectly honest, in this day and age is the third-party payments. So does anyone know what this means? What is the third-party payment? What does that refer to? These are insurance companies, right? So it used to be back when like Freud was doing his therapy and really a lot of early therapy, and honestly, therapists who live in well-off areas now, the client just pays you out of pocket for each session. Right, but a lot of people can't afford that. And so there's this insurance system where they will usually reimburse or, just pay for therapy, but they'll only do it if there's a diagnosis that they consider worthy of being compensated for treating. And so to be perfectly honest, this is the main reason we still have diagnoses and we're still using them, is because otherwise our clients would have to pay out of pocket, and we don't want to bankrupt our clients. We want them to be able to access some things. Now, this is something we'll talk more about when we get to professional issues, kind of relates to the controversies we talked about with like the apps, right? A lot of therapists are finding it really hard to get onto insurance companies as someone in network, and then stay on insurance companies, because a lot of times they're not paying very much. So like for an hour session, maybe if a therapist bills $200, they're getting like $40 from the insurance company, plus whatever copay the person has. Right, but then you sort of figure that out over the course of the week, and knowing that you have to have time to like write notes and look at assessment materials, and it becomes harder to make a living wage as a therapist. Now, there are some insurance companies that do a really good job. So as I've shared, I went through therapy following my postpartum depression and anxiety, and my insurance company, like, she charged $100 an hour. I would pay my $25 copay. They would pay her the $75. Cool, awesome, right? But my insurance company isn't the best with everything. There have been times when, they've been billed several $100s for blood tests, and I look and like the lab actually got paid $10, right? It's like, whew, I don't know how they survive, but things along those lines. So it does really suck that these third-party payers drive this right now. It also can be a way to communicate with other clinicians, whether those are other mental health professionals or like primary care doctors. If I say this person has major depressive disorder, that means something, and other people can know what that means. There also, more and more, we're finding out that a lot of diagnoses are at least partially biologically caused, and therefore you need a definitive diagnosis for proper treatment. If we're going to give someone some medication, we better make sure we're not just like throwing something at them that changes their neurotransmitters, unless we're pretty sure it's actually going to help them, right? Unfortunately, that does happen sometimes. And then it can also be helpful for case conceptualization and treatment planning, sort of what's going on with this person and what are the best things I can do to help them. All right, so what the heck is the DSM? So it stands for the Diagnostic and Statistical Manual of Mental Health Disorders, of mental disorders. Like that, for some reason, we don't include the MD. So we just do the Diagnostic and Statistical Manual. Diagnosis itself is derived from the Greek words dia, or apart, and gnosis, to perceive or know. So we're perceiving or knowing what's setting this person apart from the rest of people. So the first DSM was developed in 1952 by the American Psychiatric Association. So there are two APAs up in the world, or probably more, but two main ones in the mental health world. So there's the American Psychological Association and the American Psychiatric Association, APA. For those on Zoom, I'm just sort of writing APA. And you would think that this might be determined by the American Psychological Association, which is filled with psychologists who do research about these things, just as we discussed with prescription benefits, right? They may be the best people to do this because of all the knowledge that they give and how much they focus in on mental health issues. However, I don't even know if it was just the American Psychiatric Association thought of it first, right? But they're the ones who write it. And that in and of itself causes some issues with this document. One is that these are MDs. So although some of them do therapy, they're much more leaning towards things that we have medications for. for that reason, sometimes we'll get stuff added to the DSM that feels weird to have there. Like they added restless leg syndrome to the DSM-5, which like, not actually a mental disorder, right? Like, so it's sometimes like, oh, we have a medication, let's put it in there. The American Psychological Association and psychologists in general refer to the American Psychiatric Association as the little APA because their membership's not as big. I'm sure they do not appreciate that. So DSM-5 is the most recent version. You saw Stephen Lice hold that up. I also have a copy in my office if anyone wants to see it. So this was released in May 2013. So they're actually getting ready to possibly put out DSM-6. So just sort of like heads up that within the next couple of years, some of what I'm teaching you today may be wrong. I had to relearn everything for grad school, not everything, but several things that I learned in grad school changed when the DSM-5 came out. Before we had this system that was like, you diagnose people based on these 5 axes. I'm not gonna go into it because it doesn't exist anymore. They basically wiped that away and you just sort of give diagnoses. They revised a lot of criteria for disorders and they added new disorders. Again, some of which I think were really needed, some of which probably not so much. So each mental disorder in the DSM will describe the disorder's main features or symptoms. If there are subtypes and variations, sometimes these will even get their own code that we use for diagnosis. So in addition to names, each diagnosis is associated with a code that you put on documentation. The typical pattern, course, or progression of those symptoms. So is this something that like with treatment can get better, or is this something that like you'll always kind of get worse, but we can sort of help you function with treatment? And differential diagnosis. So how can you differentiate this from similar other diagnoses? Oops. It has 400 disorders. That's a lot, right? And this is a change for DSM-5. It used to be you just sort of put the diagnosis, right? Now you also indicate a dimensional aspect, essentially how severe their symptoms are. I really like this particular change, right? Because you can have 2 people with the exact same disorder, one of whom can generally function in their day-to-day life and the other whom like needs to be inpatient hospitalized, right? So this is really good to indicate that not everyone with the same diagnosis has the same experience. And then there's additional information about, there are usually statistics and things along those lines for each diagnosis. And there are also appendices with like disorders that may become part of the text in DSM-6. So this is, I think, pretty interesting because especially once you get into the mental health world, it could just feel like everybody has a diagnosis, at least one, right? But in fact, over half of people worldwide will never meet criteria for a DSM diagnosis in their lifetime, okay? But that does mean that almost 50% will. And I think this chart is really helpful because it points out that you can have more than one diagnosis and actually it's fairly common, right? So you have almost as many people with 3 or more disorders as the number of people with 1 disorder. So for example, when I was treating patients with eating disorders, it was pretty common for them also to experience a mood disorder, something like depression, sometimes also an anxiety disorder. And then sometimes they also had what's called a personality disorder, which is like an underlying issue. So again, just kind of interesting to think about. Oftentimes we're not just writing one thing down when we're diagnosing them. It's like very click happy today. Okay. One of the things tying to our diversity talks last week that I think it's important to bring up is that there are just some things that are not diagnosable. So client reactions to expected culturally Appropriate reactions to life events. Sorry, that's really weird wording. Basically, like loss of a loved one, like grief is expected, right? Phase of life developmental issues. We don't diagnose people with like going through puberty-itis, right? Like we just know that everybody's going to transition through that. Cultural specific reactions that may seem unusual in Western culture, right? So for example, there is a disorder called pica, where people eat non-nutritive, non-food items. And there are certain subgroups in the Deep South that like part of their cultural experience is actually eating red clay. And we're not entirely sure why, but it may have something to do with the iron in it, that they originally craved it. That wouldn't be pica because that's a cultural experience, right? And most problems people have are not diagnosable, right? Like there are just things like, I talked to an alum yesterday who's going through a breakup. Having gone through a breakup on Valentine's Day myself, it sucks, right? But you know, she's not diagnosable with anything. I wasn't diagnosable with anything when I went through it in college, right? It just means like, you're gonna feel kind of sucky for a while. Maybe you go buy that discount Valentine's Day candy today, and then you kind of get over it, right? So we don't need to diagnose people with that. So the DSM-5 made much more of an effort of this than previous versions to really point out that there are gender, cultural, and age differences for these things. Sometimes in symptom presentation. So for example, for depression, because young kids can't really tell you I feel depressed, right? They don't have the language for it. Instead, sometimes we look for, are they irritable, right? Is it, again, think about when you're trying to explain something to someone else and they don't understand you, right? But you're just feeling horrible. You get like really annoyed with that person, right? And that's essentially how it can manifest in kiddos because they don't have the language or the vocabulary to talk about it. There's also an appendix of cultural specific client experiences. So one example is Koro, which is something we see in the Pacific Islands that seems to maybe be of Malaysian origin. It refers to an episode of sudden and intense anxiety that the penis, or in females, the vulva and nipples, will recede into the body and possibly cause death. This is not something most of us experience. I mean, it's not that like everyone in that culture experiences it, but it is something that they can experience. And so we do acknowledge it. That being said, the DSM certainly has a Western and an American bias. So for example, I think for the DSM-4, there were researchers within the eating disorder field who tried to get bulimia nervosa classified as a culture-specific experience because worldwide, until Western media was introduced, we didn't see any culture that had symptoms of bulimia. Anorexia sometimes, just because sometimes that like it's the extreme of fasting for religious purposes. But because of this Western bias, it was rejected to be classified there. All right, here's my least favorite diagnosis in the DSM as a case study for gender-related issues. So this is a disorder called Pre-Menstrual Dysphoric Disorder. And I'm going to start with a caveat that there are truly women who essentially have episodes of depression every month, either before or when they get their period. And that's why this diagnosis was created, and that helps them to get medication they need for it. And that's great. However, I think the way this is phrased in a lot of ways could certainly lead to dangerous overdiagnosis. And I'll give you some examples. So in most menstrual cycles during the past year, 5 or more of the following symptoms were present for most of the time during the week of the luteal phase, begin to remit within a few days after the onset of the follicular phase, and were absent in the week post-menses. So essentially it's like pre-period, during period, and they go away after your period is done. And so you have to have markedly depressed mood, feelings of hopelessness or self-deprecating thoughts, marked anxiety, tension, feelings of being keyed up or on edge, marked affective lability, which is essentially you're suddenly having giant mood swings, persistent and marked anger or irritability. So you've got to have one of those first four, which is what redeems this diagnosis in my eyes. I still hate it, but essentially makes it something that's actually a psychological disorder. Then you get to the symptoms that are really problematic, in my opinion. So we've got things like lethargy. Yeah, a lot of women get really tired during their period, right? Marked change in appetite with specific food cravings. So literally most people with uteruses I know when they're on their period. A subjective sense of being overwhelmed or out of control. And then the physical symptoms are what really get me. Like the sensation of bloating or weight gain. Like, how is that a psychological symptom for a disorder, right? And so I think, again, I want to like give full credit. I've come a little further than I used to just be like, this is stupid, we shouldn't have it at all. I want to give full credit that there are people that genuinely benefit from this diagnosis existing. But you can easily see how it could be over-pathologized, and essentially all women or all people with uteruses who get periods still could be pathologized. Here we see that disturbance, right? The dysfunction that we talked about before. So interfering with work or school or usual social activities and relationships. It's not just, you already have bipolar disorder and it gets a little worse. And you have to have at least 2 consecutive periods with these symptoms. So again, probably disorders that aren't the best, right? But we can be critical of this. Paula Kaplan, who actually just recently passed away, was a psychologist who was very critical of issues surrounding gender. And when so PMDD was in the appendix of like disorders review their study for DSM-4. And when she saw that that was going to happen, she put in a disorder, and I forget the name of it, but it was basically like testosterone-induced mood disorder. It was like the male equivalent, and it was rejected. Because again, unfortunately, a lot of the people who make these decisions are still dudes. So. All right, so now we're gonna do like a really brief whirlwind of the DSM overview here. And if there are disorders you're more interested in, or one your person has, again, I have the DSM, the library has one. Very glad to lend you that, help you go over the symptoms, things along those lines. So this is real quick side step here. So these used to be called like disorders that originate in childhood, and they changed them to neurodevelopmental, and I really like that. Because sometimes people with these types of disorders, it gets missed when they're a kid, right? And they might not get diagnosed till they're an adult. And they also continue throughout the lifespan. So intellectual disabilities. So this is intellectual development disorder, global developmental delay. What these essentially mean is like, you're not hitting milestones that you should be hitting at, in those time frames you usually do. So this is one of the places where we used to use the term mental retardation. I don't like using that term anymore because it's basically now a slur. And so we now use developmental delay, which is more accurate anyway. Because some kids grow out of these, and like with some help, they end up fine. Then there are communication disorders. So problems with language, problems with speech sounds. Fluency disorder is stuttering, which can be psychologically induced for some people. For some folks, stuttering is entirely like when you get anxious, right? And then there's social, or what's sometimes called pragmatic communication disorder. And this is like your ability to have conversations, right? If someone asks you, how are you? Responding back to that. So autism spectrum disorder That was one of the biggest changes in this area for DSM-5. It used to be you had autism disorder and you had Asperger's disorder. Asperger's is no longer its own diagnosis. It is now subsumed under autism spectrum disorder. The argument being this is all the same disorder, it's just on a continuum. That was problematic for a couple reasons. One is that there were people who really identified with that Asperger's label. It was meaningful to them, it was an identity for them. The other is, so my husband's best friend, who was our best man at our wedding, he is involved in treating kids with autism spectrum disorders. And when this change came out, any kid that had Asperger's as their diagnosis, they had to re-diagnose because the insurance wasn't going to pay for it anymore because it doesn't exist. So it kind of wasted a lot of time and money, as you can imagine. Attention deficit and hyperactivity disorder. You can see, so if the overarching one, and then you can have it for other reasons. Specific learning disorder. The one that most people know about is dyslexia, which is difficulty reading, but there's also dysgraphia, which is difficulty writing. So some people can read just fine, but have trouble writing. And then there's dyscalculia, which is a math-specific learning disorder. Yeah, Emily.
I have a question.
Sure.
Growing up, I have ADHD. It was always considered like a learning disability. Isn't it not a learning disability?
Yeah, so it's technically its own thing. It's technically an attentional disorder, but it does get lumped with learning disabilities quite a bit. Just to give you an example, so right across our softball field, there's a great K-12 school called Chesapeake Bay Academy, and they are entirely for kids with what they call learning differences. And so they have a lot of kids with ADHD, learning disorders, and clearly there they sort of try to differentiate, but it kind of gets put under that umbrella. They also have kids on the spectrum as well, and as you can imagine, kids with multiple of those things, right? So, but I think it's really great that they exist, right? Because they're a space where the kids don't feel stigma and are able to succeed and things along those lines. But yeah, really good question. Yeah, we do tend to be like, oh, you know, that learning disorder, and it's different, right? ADHD is really, it tends to be related to issues in your frontal lobe, especially your prefrontal cortex, which is like right up here behind your forehead, which is the part of your brain that tells you how to sequence things, helps you to inhibit from doing things along that line, right? And so that's really distinct from these other things. Really good question. There are also motor disorders, so coordination disorder, stereotypic movement disorder, and then kind of subsumed under that are the tic disorders. So people think of Tourette's when they think of tic disorders. This is the disorder where people, in addition to physical tics, will also sometimes yell, and sometimes it's swear words. I remember a few years back, there was a guy who, he put up the video himself to kind of poke fun at himself, so that's okay, right? But his swear word, he would just yell as part of his tics was Bob Saget for some reason. He'd just yell, Bob Saget, right? Like, whatever works for you, man. But as you can see, there are tic disorders you can get for other reasons as well. Alrighty, here's another change. DSM-4 just had one category called mood disorders. In the DSM-5, they decided those were distinct enough to create two categories. So now we have the bipolar disorders and the depressive disorders. Bipolar, if you're not familiar, is essentially you have periods or episodes of depression, but then you also have periods or episodes of mania, which is feeling really good, feeling like you're on top of the world, feeling like nothing can hurt you, and so they tend to take risks and feel like they need less sleep and things along those lines. And so bipolar 1 is when you have full manic episodes, which are like 7 days long, or so bad you need to get hospitalized because you are just like putting yourself in so much risk. Bipolar 2 is you'll have what are called hypomanic episodes. They're less severe, they're less long in duration. Catherine Zeta-Jones about 5 or 6 years ago came out and said that she has bipolar 2 disorder, so you certainly can be fairly well functioning with bipolar disorder, right? And then cyclothymic disorder used to just be called cyclothymia. And it's like you have sort of low grade depression a lot of the times, and then you'll have hypomanic episodes in between. So it's sort of like mild bipolar disorder. I don't know. It's sort of a weird way to put it, but the other thing that DSM-5 did that's new is they took some of the disorders that used to be classified under those disorders in childhood, and rather than lumping them all within their developmental disorders, they spread them out throughout the DSM to places where they fit better. And so, for example, this disruptive mood dysregulation disorder, that is a disorder of childhood, but it's a mood disorder, so it got put here. This is another diagnosis that is controversial for some people. Some people feel like this is just pathologizing kids who, get moody sometimes or throw tantrums. Again, there are specific criteria, but we need to make sure they're being applied accurately. Major depressive disorder is what we just think of, it's called depression. So this is the technical term for it. You have markers for major depressive disorder based on the number of depressive episodes they've had. Depressive episodes are episodes of at least 2 weeks where you're feeling depressed or down most of the day, nearly every day, and or losing interest in activities you usually enjoy, along with some other symptoms. So you might have single or recurrent episodes, and then there are also specifiers based on whether it's mild, moderate, severe. Persistent depressive disorder is essentially cyclothymia, but without those hypomanic episodes. So it's like you're just kind of feeling depressed, but not depressed enough to be in a depressive episode for, I think the criteria are at least 2 years. So can be challenging. And then here's where PMDD is classified as well. Okay, there we go. Alrighty, so anxiety disorders. After mood disorders, anxiety disorders are the most commonly diagnosed, or the second most commonly diagnosed disorder. And again, here we've moved some disorders of childhood. So separation anxiety and selective mutism are disorders of childhood. Separation anxiety is just what it sounds like. They have a really hard time being away, usually from their caregivers, whether that be parents or whomever. Selective mutism is where the children are physically able to talk, but because of their anxiety, the vast majority of time they don't. Specific phobia is what we think of when we think of phobias. This is like being afraid of a object, a situation. So things like arachnophobia, claustrophobia, all fall in here. Social anxiety disorder used to be called social phobia. I like the social anxiety disorder label better. Just feel like it's more accurate. But this is getting really anxious in social situations. And this can be sort of like generalized or be kind of more social specific. Or for some people, this is like really specific to speaking in public, for example. The really nice thing is for people who like that's their issue, they can take a fast acting anti-anxiety medication like on the day they're going to give a speech, and it helps in the moment. Panic disorder, just what it sounds like. People who have repeated panic attacks. Panic attacks, if you're not familiar, are where you really quickly get a lot of psychological and physiological symptoms. You can feel like you're having a heart attack, you can feel lightheaded, you can feel like you're going crazy or that you're gonna die. They usually resolve fairly quickly, but you get physiological sensations like your heart racing, your extremities can get numb, you can get nauseous and lightheaded. And it's all because This is actually a overreaction of your fight or flight reflex. So basically, when you are in a situation, let's say a bear walked into this classroom, promise I didn't like plan that. So I covered as far as I know, right? And oh, Elijah, go ahead.
I had a question. Like, would hypochondria be considered an anxiety disorder? Anxiety disorder?
Say it again.
Like,
Disorder.
Would hypochondria? Would
Oh,
that,
that's really
like,
interesting. So it's classified with the like body related disorders, but they've actually changed the name to illness anxiety disorder. So I would argue, yes, that it is actually an anxiety disorder. That's such a good question. So he was asking about hypochondria. Yeah, great question, Elijah. Thanks for interrupting me. Yeah, but that's classified with the like body related disorders. But yeah, if a bear walked in, your body would like kick into action, right? So the heart starts pumping to get blood flowing, your extremities feel numb because it's like putting it to your major muscle groups like your legs so that you could like kick or run. You get nauseous because it stops digestion, because it's like we can digest the food later. We need to focus all our energy here now. The reason you get lightheaded is actually because it slows the blood flow to the brain, because it's like, we don't need to stop and think right now. We just need to act. So all the symptoms of a panic attack are actually the fight or flight response when we don't need it. Agoraphobia translates to fear of the marketplace. These are people who fear going out in public places with a lot of people. This used to be just classified with panic. And it was like you were afraid to go out because you're afraid you'd have a panic attack. Now they've sort of separated it. Typically there is some sort of fear of having some sort of attack, but it could be you have Crohn's disease or IBS, or you have epilepsy and you fear like a seizure or some sort of diarrhea related incident in public. Some people with agoraphobia get so bad that they just like don't leave their house anymore. And generalized anxiety disorder is the one people know least about, but is the most common anxiety disorder. It is just worrying about everything all the time. So like if someone came to me when I was treating clients and they're like, oh, I've always been a worrier. I was like, we're gonna screen you for generalized anxiety disorder. And this can interfere with your sleep. You can just feel keyed up or on edge all the time. Now, OCD used to be classified with anxiety disorders. And again, here in DSM-5, they decided, no, that's different enough. We want it to have its own category. So now we have obsessive compulsive and related disorders. So we've moved other disorders into this category. OCD itself is, you have obsessions, thoughts about things that almost feel like someone else planted them there. And in order to relieve the anxiety from those thoughts, you have to engage in compulsions, which are behaviors. So the typical one people think of is washing your hands because of obsessions with contamination. I'm sure this is an awful time for people with that type of OCD, right? But a lot of times it's also like checking behaviors. Like, oh, did I unplug my curling iron? And you go back like 10 times to check it. It can be like counting and things like that too. I had a friend in college who had to count like the same number of steps between trees on our campus, and he'd actually sort of like walk backward a little and redo it if he needed to. Luckily, the way I knew him was from our ballroom dance club, so we just thought he was practicing when he did that. And then body dysmorphic disorder is here now. This is a belief that a feature of your body is horrific, essentially. So a lot of times this is like facial features where you're like, oh, my nose is too big, my ears are too big, things along those lines. And they constantly engage in checking behaviors and may get to the point where they're like undergoing surgeries to try to alter those pieces. Hoarding, I always kind of laugh because it is a thing and it probably needs a diagnosis, but like it didn't make it into the DSM until after the show Hoarders came out. So it's sort of like, really, right? But so hoarding is essentially where you Your obsession is, if I throw anything away, horrible things will happen. And what that can lead to is just horrific situations, right? If you've ever watched the show Hoarders, like there's living in trash heaps sometimes. Other times it's just like stacks to the ceiling of newspapers and things along those lines. Sometimes really sadly, it's animals. Animal hoarding is often really horrific for the animals because that person just can't care for all the animals they have. So yeah, clearly a disorder, but it's just funny that they're like, oh, it's a TV show, we'll stick it in here. Trichotillomania is hair pulling. And so this is, when they're anxious, usually, they'll sit and they'll just pull out their hair, sometimes without even really realizing it. And it can be hair anywhere on their bodies. So I had a student who was really open with me about her trichotillomania once. And she came in to meet with me one day and like half of one of her eyebrows were gone. And I was like, okay, we're having a bad day, right? Essentially, it is like a compulsion, like they can't stop doing it. And then excoriation is skin picking. So it's like you get a cutter and you always pick off the scab, and that makes it worse. And it's very similar to trichotillomania in that it's something you might not even realize you're doing. Alrighty, then we get to the dissociative disorders. DID, or dissociative identity disorder, is what used to be called multiple personality disorder. So this is typically seen in people who have horrific experiences of trauma. And the theory is essentially your brain kind of parcels out a piece of itself, compartmentalizes so much that it's almost like two different personalities, two different people in your mind. And the new one that's made will have like memories of the trauma, but then your main personality won't. These are sometimes called alters as well, like alternate personalities. It's not as common as Hollywood would have you think. But despite what some psychologists have argued, it does seem to actually exist. There are psychologists who think it's all made up. You know, I had 3 very respected supervisors when I was in grad school who had each seen over the course of their 20+ year career, 1 case each. So I think it exists, it's just super rare. And unfortunately, whenever movies come out about it, all of a sudden, like everyone thinks that, right? That happened after Sybil, for example, came out. Hang on just a sec. Yeah, sorry, my over exuberant clicking made me miss something. We'll get to dissociative disorders again in a second. Schizophrenia spectrum and other psychotic disorders. These are a loss of connection with reality. These folks will hear things, see things, touch things, smell things, taste things that are not actually there. These folks will believe things that are clearly not true. And again, here we've moved some disorders. So schizotypal personality disorder is a disorder that typically is with the personality disorders, not surprisingly, but they put it both here and there to acknowledge sort of the overlap with schizophrenia. Delusional disorder is just having those fixed false beliefs, things like the CIA is after me, you know, aliens stuck a probe in me, things along those lines. Brief psychotic disorder is where you have the symptoms of schizophrenia, but it's like really short, like a month or less. Sometimes people will have this and then they'll just go away. Just maybe something really stressful happened in their life that made them have what we call a psychotic break, and then they're able to return to normal. Sometimes that goes into schizophreniform disorder, which is having psychotic symptoms for 6 months or less. And then sometimes that goes all the way into schizophrenia, which is what we typically think of. Unfortunately, schizophrenia is one of these disorders that we're never ever really able to cure. We can certainly help them function better with medication and with therapy. There's a lot of great research that's been done with therapy for these folks. But it's never going to all the way go away, and it tends to be degenerative. Schizoaffective disorder is when you develop the symptoms of schizophrenia and the symptoms of a mood disorder, so either depression or bipolar disorder at the same time. So you can't distinguish the two, so you diagnose this disorder. And then catatonia is like a subset here. Some people with really severe schizophrenia will become catatonic. They will just sit for hours. Sometimes they have what's called waxy flexibility, where they'll like hold weird poses. And then if you were like, oh, I'm worried about their arm, you could just like kind of mold them like an old Gumby toy. Very interesting. All right, PTSD also used to be an anxiety disorder, gave it its own category. And again, it's now trauma and stress-related disorders. So they've put things like reactive attachment disorder, which is a disorder of childhood related to stress. They've put disinhibited social engagement disorder, again, a disorder of childhood. And then PTSD. So PTSD is, you have to have experienced a trauma. We call this a criterion A event. So something where either you think you are genuinely experiencing, or someone around you or close to you is either in danger of bodily harm, experiences bodily harm, in danger of death, or dies. And this includes things like auto accidents, sexual assault, things along those lines. We used to think this only could happen in combat veterans, but we know now it's actually much more common in civilians for things like, a car accident. Acute stress disorder is essentially similar to brief psychotic disorder. It's a month of symptoms. For some people, they only have PTSD-like symptoms for a month and then they're better. For some people, after that month mark, they'll be diagnosed with PTSD. Adjustment disorders are disorders related to stressors in your life, where you have like some symptoms of a disorder, but not enough to meet full criteria. So for example, you could have an adjustment disorder with depressive symptoms or with anxious symptoms. Okay, now back to dissociative disorders. So we talked about DID. Dissociative amnesia is where something really stressful happens in your life and you like forget it, but not because you've been hit on the head, just because sort of your mind can't process it. There's also a type of dissociative amnesia that's called a dissociative amnesia with dissociative fugue. And this is when someone will actually like pick up and move, sometimes to the next town, sometimes across the country, and like take on a different life, and they're not doing it consciously. Very interesting. Depersonalization, derealization disorder is where you feel like depersonalization, you feel like you're sort of like not attached to yourself, outside yourself, watching yourself. Derealization, you feel like the world's not quite real or you're not really connected to it. Now, one thing I'll say, most adults have had at least one experience of derealization or depersonalization in their life. And that doesn't mean you have this disorder, right? This is a repeated experience of that. All right, hang on just 1 second. My nose is running under here, allergies. I'm just gonna go blow my nose, I'll be right back. Luckily, my office is right there. All right. Then we get to the somatic disorders. These are the body-related disorders that I was talking to Elijah about a couple minutes ago. Somatic symptom disorder is where you have physical symptoms as a result of psychological stress. Illness anxiety disorder is what I was just talking about, is the new term for being a hypochondriac. They now call it illness anxiety, that you're just always worried you're going to be sick. Conversion disorder is also called functional neurological symptom disorder. This is where you have specific neurological symptoms, even up to the point of like paralysis, that are caused by psychological things. There's no physiological explanation for them. And then you can have other psychological factors. And then factitious disorder is what used to be called Munchausen syndrome. And so what this is that you either have factitious disorder of self, where you purposely make yourself ill. So take things to produce symptoms, things along those lines. Or the worst one, in my opinion, is factitious disorder of another, what used to be called Munchausen by proxy. And this is where someone who has power over another person, typically a parent or guardian, will purposely make their kid sick. And like, I just, even before I had a kid myself, it just always makes me really mad when people do stuff to kids, right? And so these kids will have to like have surgeries and treatments and whatnot, and it's just the parent doing it the whole time. It's obviously a form of child abuse, and you can be prosecuted for it. Alrighty, now we have other disorders related to bodily functions. So we'll start with the feeding and eating disorders, which is where my area of specialty is. I mentioned pica earlier. This is another disorder that used to be classified in childhood disorders, got moved to this category here. Eating non-food, non-nutritive substances. So a lot of my strange addiction is people with pica. So people who eat glass and dish soap, and that's all pica. Rumination disorder is where you will like chew your food, spit it out, or like just chew and chew and chew it, but not actually take it in. It's called rumination because cows, for example, are ruminants. And this is, if you've ever heard the term cud, the cow is chewing its cud. Just the way the cow's digestive system works, they have to like chew and swallow and like bring it back up and chew it some more. Kind of gross if you think about it, right? And that's called rumination. Avoidant restrictive food intake disorder is really interesting. When I go to conferences, a lot of people are focusing research on this now that work with kids, just because we really don't know that much about it. So this is kids who like are either like limiting themselves to only a certain kind of food or just terrified of eating, but it doesn't have to do with like losing weight, right? There's just something about the process of eating or eating certain things that's terrifying to them. And then we get to the traditional eating disorders. Anorexia nervosa is not maintaining what's considered, like a healthy weight. Oftentimes they're very thin. In kids, it's like not gaining weight, right? Because they typically are like gaining weight as they get older. Bulimia nervosa, binging, eating large amounts of food in a short amount of time with a sense of loss of control. And then some sort of compensatory or purging behavior. And so we again tend to think of things like vomiting here, but it can also be use of laxatives. It can be things like using water pills. It can be excessive exercise, things along those nature. Even fasting can be a purging mechanism in bulimia. And often they use a combination of these. Binge eating disorder was a disorder for future study in DSM-4, got moved up here in DSM-5. And so this is bulimia without the compensatory behavior. So they're still engaging in the binges. It does, for some people, lead to severe obesity. Elimination disorders are disorders related to urination and defecation, where you have issues around that because of psychological issues, like terrifying for you or your bedwetting, things along those lines. Then we get to the sleep-wake disorders. So insomnia disorder, just what it sounds like, really hard time sleeping. Hypersomnulance disorder is the opposite. You're just sleeping a lot. Narcolepsy is distinct here. So narcolepsy is where you be totally awake, maybe you've been sitting in class, and then just fall asleep out of the blue. As you can imagine, this can be pretty terrifying. Like the person is driving, right, and they fall asleep. Then, for whatever reason, they added sleep apnea here. Again, to me, this seems like a biologically based disorder, but I guess there could be psychological features. And certainly it has psychological ramifications. Sleep apnea, if you're not familiar, is where due to like how your airway works, you actually stop breathing for little points of time while you sleep. Every time you stop breathing, there's less oxygen to your brain. So you can actually, over time, get some brain damage from sleep apnea. And then circadian sleep-wake disorders would be, you just can't set your internal clock to match sort of normal sleep-wake cycles. You might want to sleep in the middle of the day, and it's not just like normal, like I'm tired, so I want a nap, right? It's just like, it's really hard for you to regulate. Parasomnias include things like not having REM sleep. So REM sleep, rapid eye movement sleep, is the part where we do most of our dreaming. There's a lot of studies to suggest that REM is really important for us biologically as well as psychologically. It helps our bodies kind of like reset. It's like turning a computer on and back off, things along those lines. So not having that type of sleep can actually mean you're having less helpful sleep, less deep sleep, less fulfilling sleep. There's also sleepwalking. Obviously can be pretty dangerous if the person walks out of the house or something like that. Sleep terrors are where you wake up. Sometimes this is with sleep paralysis, and it's just like horrible, horrible, horrible nightmares. And sometimes you feel like you can't move. Absolutely terrifying. Nightmare disorder, just what it sounds like. And then rapid eye movement sleep behavior disorder is during REM sleep. You have very distinct behavior that you wouldn't see typically in a person. And then, as I mentioned, restless leg is here. Sure. All right, we're getting there, I swear. Next is sexual dysfunctions. So these are psychologically related difficulties with the actual physiological part of the arousal cycle. So delayed ejaculation or erectile disorder for men, female orgasmic disorder, female sexual interest arousal disorder for women are just, sorry, there's like a random cut and paste error here. I'm just gonna take care of it. Oops, made it worse. I should know, as I've learned during the pandemic, I cannot click and talk at the same time. So I should just not. Okay. So those are difficulties getting aroused, staying aroused, things along those lines. Sometimes it's just no interest in sex. Genital pelvic pain or penetration disorder is where often because of something like sexual trauma in their past, people with uteruses and vaginas struggle and actually can have like physiological responses to trying to have sex even if they want to. And then there's male hypoactive sexual desire disorder, which is like the equivalent of the female sexual interest disorder, early ejaculation. And then they're fully acknowledged that there are medications you can be on that can interfere with this. All right, so gender dysphoria used to be called something else that I'm blanking on. Jeez, that's okay, because it's not a great term. You shouldn't use it anymore. But this is essentially the diagnosis that's often given to trans individuals that allows them to get gender affirming. So this diagnosis basically says, I am so dissatisfied with the gender I've been assigned, typically because it doesn't align with what that person truly is, that I need help to transition to be more like the gender I want to be. And this could look really different for different people. Some people will just change the way they dress. Some people will just do hormones. Some people will go all the way and have surgical procedures, right? And that's totally up to the individual. And this is certainly debated. And I was actually having a conversation with little Wilma about this yesterday, that it's like, right now we need it for the exact reason I talked about at the beginning with the third-party payers, right? This is the only way right now, if you have this diagnosis, to get your insurance company to pay for your gender affirming care. But gosh, I wish we didn't need to like pathologize people who are trans, right? So I hope that in the future we figure out a different way to address that. Okay, then we have disruptive impulse control and conduct disorders. Again, we've moved some childhood disorders here. ODD, oppositional defiant disorder, is kids that really just like will not listen to adults, always arguing with them, things along those lines. Intermittent explosive disorder, kids that have really big tantrum. And adults can get that too, actually. Conduct disorder is essentially the teenage version of antisocial personality disorder. Antisocial personality disorder is the technical diagnosis for people who are both psychopaths and sociopaths. So these are often your serial killers, your Wall Street people who don't care when the bubble bursts, right? Things along those lines. So they have like a lack of caring. They just do what they need to do for themselves, things along those lines. And it can be violent. It can be like killing animals, killing other people. Pyromania, you like setting fires. Kleptomania, you like stealing. All right, then we have the substance-related and addictive disorders. And so there's another place where we used to have more distinctions, and they've kind of collapsed it down. It used to be like substance abuse and substance dependence, which sort of specify between whether or not you were physiologically dependent on the substance or not. But now they're just substance use disorders. And so as you can see, we classify these by the type of substance you use. Alcohol, you can have caffeine-related disorder, right? If you've ever stopped coffee cold turkey, if you're a coffee drinker and you get like a migraine headache, you are physiologically dependent on caffeine. But for most people, it's not actually a psychological disorder, right? Cannabis-related disorders, hallucinogen, inhalants, opioid, obviously that's a big one right now. Sedative, hypnotic, or anxiolytic. Again, I think it's really important to point out these two in particular are prescription medications that are abused, right? Whether pain-related or anxiety-related. Stimulant related, so this can include things like cocaine, that's a stimulus. It can also include things like medications for ADHD that people abuse. Tobacco related, and now they're kind of playing with like addictive disorders that aren't substance disorders. So they've got gambling disorder, and some people have proposed like an internet use disorder for people who that becomes pathological. Now, just by using one of these substances does not make you have this disorder. It's when it interferes with your life, your work, things along those lines. All right, and then we have what are now called the neurocognitive disorders. You can either, again, if we're talking about severity, either have major or mild. Oftentimes with these disorders, you sort of start mild and then unfortunately go major. A lot of these are degenerative. A lot of these we have not been able to establish cures yet for them. And so The most commonly known one is neurocognitive disorder due to Alzheimer's disease. But you could also have it due to a whole bunch of other things. So there's something called frontotemporal dementia you can get, or Lewy body dementia, vascular dementia comes from having strokes, whether it's one big stroke or a bunch of mini strokes or what are called TIAs. Neurocognitive disorder due to TBI, traumatic brain injury. Things like what we're seeing in NFL players, right, which fall under this. Can be from substances, right? You've overdosed on drugs, or maybe you were misdiagnosed with medication. HIV, so it's really when you get to AIDS, like, so HIV is how the virus starts. And if you aren't treated, like HIV can now be really well controlled. And in fact, Moderna is playing around with a vaccine for it. But if you get to full-blown AIDS, what can happen is something that looks like other dementias, unfortunately. Prion disease, Parkinson's disease, Huntington's disease. So all of these neurological disorders can lead to these neurocognitive problems. All right, last couple things here. I think I can jet through these in the next couple of minutes. Personality disorders. Quick note on these. Maybe I won't get through these. That's okay. We can wrap this up on Thursday because I need to tell this story. So there are supposed to be brand new personality disorders in the DSM-5. The working group spent a lot of time working on these. They submitted them in, I think, October or November 2012. And the people who run the DSM said, oh, I'm sorry, you're too late. We can't put those in now. So there are actually two different versions of personality disorders in the current DSM. They took the DSM-4 one, copy pasted it, and that's in the main text. And then there's an appendix of the proposed new personality disorders. And that's what really gets to me. Like, you could put in the new proposed ones, but not in the main body of the text. Anyway, so we still use these, and we'll talk about those and do the last couple of slides related to this on Thursday, and then we'll talk about the intake interview as well. All right, like I said, I promise not to lecture this much most of the time, but this is just like stuff we got to get through. So thanks for bearing with me, both people in class and people on Zoom.